This is the Delta Squad waveform video. First up, we have normal sinus rhythm, or NSR. It's a regular heartbeat originating from the SA node, generally between 60 to 100 beats per minute. It has regular, evenly spaced P waves, QRS complexes, and T waves. Everything is normal, so it does not require treatment. Here is what that looks like on an EKG. Next up, we have sinus tachycardia. It's an elevated heart rate originating from the SA node, but other than the elevation in the rate, there's nothing abnormal about it. So there's regular P waves, QRS complexes, and T waves, but it's just faster. It can occur due to stress, anxiety, fever, etc. You would treat it by managing stress, treating fever, dehydration, adjusting any medications, or addressing any underlying medical conditions that are contributing to the tachycardia. This is what that looks like on an EKG. Next up is sinus bradycardia, which is a slower than normal heart rate originating from the SA node. Again, it looks very similar to normal sinus rhythm. It's just slower. It occurs when the SA node generates electrical impulses slower than normal. Can be caused by vagal tone, medications, hypothyroidism, or athletic training. You would treat it by discontinuing any medications that are causing it, treating underlying medical conditions, or implanting a pacemaker. This is what that looks like on an EKG. Junctional tachycardia, or JTAC, is a usually rapid heart rate that's exceeding the normal range that would look like a junctional heart rate. So on an EKG, there's narrow QRS complexes, and then absent or inverted or abnormal P waves and a rapid heart rate. This may result from factors such as digitalis toxicity, myocardial ischemia, or enhanced automaticity of the AV junction. You would treat it by discontinuing any medications contributing to the tachycardia, managing the ischemia, or using any antiarrhythmic medications to control the heart rate. This is what that looks like on an EKG. A junctional heart rate looks very similar to junctional tachycardia, but it's significantly slower, so it's between 40 to 60 beats per minute and is regular. So it'll have, again, an abnormal, absent, inverted, or in the wrong place P wave, a short PR interval, and a frequently narrow QRS. This happens when the AV node or HIS bundle is not working properly, and if it's determined that treatment is needed, a pacemaker may be put into place, or if a certain medication is causing the rhythm, that may be changed. This is what that looks like on an EKG. Next up is V-escape, or IVR. This typically has a rate of 20 to 40 BPM, and it is lower than the normal sinus rate with wide QRS complexes and absent preceding P waves. This may occur in response to bradycardia, heart block, or other conditions, and is treated by correcting electrolyte imbalances, managing any myocardial ischemia, or adjusting medications. This is what that looks like on an EKG. Next is ventricular fibrillation, or VFib. It's a heart rate between 300 and 400 BPM with no regularity or rhythm, so it has very rapid, irregular waves. The most common cause is an acute heart attack, and there are other causes as well. The first treatment for VFib is immediate CPR, and then defibrillation is the next step. This is what that would look like on an EKG. Next is supraventricular tachycardia, or SVT. It is a dysrhythmia originating at or above the AV node with 140 to 180 BPM. This would have narrow QRS complexes with a regular or irregular rhythm and absent or abnormal P waves. It could occur due to various factors such as atrial fibrillation, atrial flutter, or others, and is treated by vagal maneuvers, medications, or electrical cardioversion. And this is what that would look like on an EKG.
Okay, so next we have ventricular tachycardia. It is a cardiovascular disorder that causes the heart's ventricles to beat too fast, and it looks like a wide QRS complex that is greater than 0.12 seconds. It occurs when the lower chamber of the heart beats too fast to pump up and the body doesn't receive enough oxygenated blood. This abnormal electricity activity results in rapid and sustained contractions of the ventricles, and it is treated through emergency management to stabilize the patient and restore normal rhythm. Here's a picture of the tachycardia. Next we have torsades de pointes, which is a polymorphic ventricular tachycardia with a characteristic twisting pattern. It looks like rapid irregular QRS complexes, which appear to be twisting around the EKG baseline. It's associated with conditions that lengthen the QT interval, and it's caused by an electrical problem called long QT interval, and is treated by discontinuing or adjusting medications that prolong those QT intervals. Here's a picture. Next is the systole, which is absent rate, regularity, and rhythm, and it will appear as a flat line. It can be caused by a number of factors like hypothermia, hypoxia, electrolyte imbalance, and more. It means that the patient's heart has stopped beating on its own and is treated by high-quality CPR and administration of epinephrine. Here's a picture. Next is atrial fibrillation, and it is a frequently fast rate where there are no visible P waves or PR intervals. The QRS complex is irregularly regular, and there are present T waves. What it looks like on EKG is that there will not be any visible P waves, and the QRS complex is irregular, and it can occur due to high blood pressure, cardiomyopathy, or there's no P wave due to the SA node not functioning, and it can go on its own. Otherwise, it can be treated with some blood thinners, beta blockers, and lifestyle changes. Here's a picture of atrial fibrillation. Next is atrial flutter, or A-flutter, which is a usually fast rate, and P waves have a high amplitude, and QRS complexes are generally narrow. The P waves are very distinct, and they have a high amplitude relative to the other waves, and it can happen due to heart failure, hypertension, alcohol, etc. And it's the way it is because rather than electrical activity originating in the sinus node, it starts in a larger circuit that causes the atria to beat rapidly, and it can be treated with radiofrequency catheter ablation of the CT. Here's a picture of atrial flutter. Next is AV block first degree, which is interpreted by a PR interval on an EKG longer than 0.2 seconds. It looks like prolonged PR intervals where the duration between the onset of the P wave and the onset of the QRS complex is consistently longer than normal, and it means that the intrinsic AV node disease and enhanced vagal tone, acute myocardial infarction, and particularly acute inferior wall are some of the most common causes of these blocks. And it occurs when there's a delayed connection of electrical impulses from the atria to the ventricles. And it generally does not require treatment, but you may require counseling on worsening symptoms. Here's a picture of AV block first degree. And then we have AV block second degree type 1, where the PR interval is consistently too long and the QRS complex is too narrow. And it looks like the PR interval, being too long. And then what happens in the body is it can be a result of myocarditis, increased vagal tone, status post-cardiac surgery, and medications, etc. It is the way it is due to the increasing delay of the AV nodal conduction. If the patient is asymptomatic, then it may not require treatment. But if they are, then they may need medication. Here's a picture of the AV block second degree type 1. And then finally, the AV block second degree type 2 is a widening PR interval that has no conduction of the P wave, and PR intervals will progressively get wider until the P wave is not conducted at all. And this means that it can be caused by a multitude of conditions: natural aging, acute rheumatic fever, hypothyroidism, etc. And it's the way it is because the AV nodal conduction gets increasingly worse until it fails. They will likely recommend a pacemaker. And here's a picture of the AV block second degree type 2.
So AV block third degree is ventricular and atrial rhythms are regular, rate about 60. Normal and consistent P waves, varying PR interval, appears like a wide, irregular IV rhythm. So there's many causes, and it's an absence of conduction between the atria and the ventricles, which compromises cardiac output, and it can be treated with atropine or pacemaker. Here's a photo. Left bundle branch block. So for partial QRS duration is greater than 0.10 seconds, but less than 0.12, with the R wave peak time greater than or equal to 0.06 seconds. So for complete, the QRS duration is 0.12 or more. And so somewhat wide QRS interval is for both of these, but the complete is wider. So many things can cause this, and the left branch of the conducting system is either partially blocked or completely blocked. So a pacemaker may be recommended. Here's a photo. Right bundle branch block. So partial has a QRS duration between 110 and 120 milliseconds, and complete has greater than or equal to 120 milliseconds. And so the QRS complex is too wide for both of these and is wider in a complete. Diseases may cause this, and the electrical impulse to the lower right chamber of the heart is either partially or completely blocked, and that creates a delay in electrical activation and contraction, and a pacemaker also may be needed. Here's a photo. Wolf Parkinson White, and so the PR interval is less than 120 milliseconds, prolonged QRS complex, and a QRS morphology consisting of a slurred delta wave. So this is a condition, it's present at birth, but most cases the cause isn't known, and there's an extra electrical connection in the heart, and that causes a kind of reentry circuit and causes the heart to beat abnormally fast for periods of time. And you can treat it many different ways, such as vagal maneuvers, medications. Here's a photo. So delta or Osborn waves. So a positive deflection is seen at the J point in the precordial inferior limb leads. So it's most commonly associated with hypothermia, and this slows down the rate of depolarization and repolarization of cardiac cells, and that leads to a delayed activation of ventricular myocardium and the appearance of the waves. So rewarming the body tends to resolve this problem. Here's a photo. ST elevation myocardial infarction. On an ECG, it presents with a ST segment elevation greater than 1 millimeter and at least 2 contiguous leads, and could be accompanied by pathologic Q waves. And it occurs due to the sudden occlusion of a coronary artery, leading to inadequate blood supply, and it can result in ischemia and subsequent necrosis, and urgent reperfusion therapy is needed to restore blood flow. Here's a photo. So ischemia has a flat or down-sloping ST segment depression of 1 millimeter or greater, and it occurs when the blood supply to a particular tissue in the heart muscle is insufficient to meet its metabolic demands. Administering oxygen-giving medications and performing certain procedures can help to treat this. And here's a photo. And that's all, so thank you for watching.